So I am a college nurse. I've worked in a college in Cambridge for the last 4 or so years. And prior to that, I worked in the NHS as a resuscitation training officer and also an A&E nurse. My background from the age of 17 onwards has been in care or health. So 30 years now. I know you're thinking I don't look old enough, but 30 years of working with young people, elderly and now teenagers. So initially when I started my college nurse role, I was working at a college called Queen's College in Cambridge. And so all of the guidance the guidelines that I'm going to talk about now was developed while I was in that role. I have now swapped to a different college, and St John's has been mentioned because of that reason. So the first thing I knew about anaphylaxis was as a A&E nurse. I don't have any children with anaphylaxis. I don't know any children with anaphylaxis personally. I do now, obviously through my work, but I didn't at the time. I was an A&E nurse and I saw people come in reaction. And I was aghast at what I saw. I was quite a naive person working in A&E, and I saw the reactions firsthand, and unfortunately I saw the outcomes of some of those reactions. It was astonishing to me that in this day and age when there is rescue medicine, why people die still from anaphylaxis. And the numbers aren't changing, which is tragic, but we'll cover that a little bit later. The title of my talk today is a Maverick approach. I'm not going to dwell on that now, and you'll learn why later. So this slide is to represent the good work that we've done in Cambridge by saving 4 lives in 18 months of individuals using a generic auto-injector provided by a college in Cambridge. 4 lives. I'll tell you a bit about these people. Obviously, I couldn't use their real photos. I wish I could. But the first lady on the left was a lady, a middle-aged lady, a known anaphylactic risk, and she was having a dinner and she developed a reaction and she got a generic device and used it. She didn't have her own with her. The next young lady on the right was a student who'd gone to another college for a formal dinner, and again, although she knew she was at risk, she did not have a device with her. The lady on the bottom left was a member of staff. Again, known to be at risk, did not have a device with her. And the chap on the right was a visitor to Cambridge. He'd come on open day and he was looking around the colleges, so a potential new student, and he went to a restaurant in his break at lunchtime before he carried on his tours, and again, he had a reaction. He did not have a device with him. So all 4 who knew they were at risk did not have their devices with them. So I'm going to tell you a little bit about the organisation in which I work, because unless you are known, have any information about Oxbridge and the establishment that I work in, it won't be familiar to you. So the University of Cambridge is the umbrella organisation. It was founded many, many years ago, as you can see, and there are approximately 11,000 staff in over 150 departments working in Cambridge. Members of both the university and the colleges are involved with running both the university and the colleges. So they coexist, but they work together too. And the university has its own occupational health and safety departments, as do the colleges. So there's a lot of people involved in decision making. In 2016, just under 20,000 students were enrolled under the Cambridge University Collegiate System. So we have 31 Cambridge colleges, and you can see Peterhouse being founded in 1284 as the oldest, and Robinson the newest, just been founded in 1977. So those 20,000 students will go to any one of the 31 colleges. St John's itself was founded in 1511. If I say to you that things don't move ever so quickly in a university establishment or a collegiate system, you will see by the next little phrase which says, first female students matriculated in St John's in 1982. So things don't move ever so fast. Across the colleges, across the 31 colleges, there are only 21 college nurses. And that's because some colleges don't have college nurses for their own reasons. And some colleges share a college nurse. So we have one poor college nurse who works across 4 different colleges. She's absolutely shattered, I can tell you. I'm lucky in that I work full-time in my college, and I did when I was at Queen's. So 3 colleges who don't have a college nurse will rely totally on the support services in the city through GPs and the like. So St John's itself first appointed a college nurse in around 1935. So we've been in colleges for a while. And at that point, we were given the title of matron. We don't really use that now so much, but we are all professional, autonomous, and sole responsibility. We don't work alongside a GP in any of the colleges. So we have sole responsibility for the students and staff under our care. So it brings me now to how I became involved with anaphylaxis. And it's through this little booklet. This booklet was produced by the Anaphylaxis Campaign quite some years ago. It hasn't got a date on it, but I know that it must have been quite old looking at the print, okay? And I found it in a drawer when I started at Queen's College. And I read it with interest. And because of my background in resus, I was keen to know what we could do in the community to manage such a condition. And this information, 1998, Laura Thrasher, an 18-year-old student, died at a Cambridge college. She'd arrived as a fresher, keen to start her academic career, keen to fit in with her friends. She was known to have allergies, but unfortunately the medical profession let her down, and they advised her that she did not need to have any skin prick testing done, that she wasn't at risk of a serious allergy. Obviously she was, because unfortunately she went to her first formal dinner, no doubt excited and exhilarated to be in this new environment. She asked, were there nuts in the dessert? And for whatever reason, she was told there wasn't, and there was. And she died in her room, having been able to make a phone call to her boyfriend, but not being able to get any further help. Now, that was nearly 20 years ago, and it astonished me when I read that 20 years later, we still did not have the means to save a life in a university community. So some statistics for you. Some of these won't come as a surprise. If you've been coming to the campaign conference or you're up to date with your statistics, these will be no surprise. But in 20 years, up to 2012, a 615% increase in the rate of anaphylaxis admissions to hospital in the UK alone. I think that's astonishing. Nut allergies, of which we know the prevalence is around 1 in 50 of primary school-aged children in the United Kingdom, and that's about 2% of the general population. 1 in 50 of those primary school-aged children. Now, most children nowadays will go on to further education or higher education. And we know now that the fatalities, as you can see there, the Anaphylaxis Campaign keep their unofficial figures of the cases that are reported to them, and that's been around 10 to 16 deaths every year since 2012. So people continue to die from anaphylaxis. An anaphylaxis type reaction occurs 1 in 1,000 of the general population. In St John's College, we have just under 1,000 students, and 22 of those carry an adrenaline auto-injector, or should carry an adrenaline auto-injector. And that's just over the 2% of the average, as you can see. So anaphylaxis across the whole University of Cambridge is likely to affect around 400 students of those 20,000, and that's not including the staff members of the university. Those of you who are parents of teenagers or work with teenagers will know that teenagers are troublesome. They don't always do what they're supposed to do. They don't always do what you tell them to do, and they're not always on their game when it comes to their own health. So these are some of the reasons why this is such a problem. Transition into adulthood. All sorts of things going on biologically, physiologically. Their emotions, their social situations are changing. Everything is changing for them. And that transition, even if they're not away at a university living with a condition such as anaphylaxis, is not easy. Risky behaviour, the trying the foods to see if they react. I've heard of this, and it comes through in the evidence as well, but sometimes they do try themselves and test because they haven't had a reaction since they were children. They don't necessarily feel that they're at risk anymore, and sometimes they do test. They're also not sure or always feel safe of the environment that they're in. So there is peer influence too. Sometimes they decide that they don't want to carry their devices because they're quite big, they're quite cumbersome, they don't fit in a small tiny handbag to go to the nightclubs with. That can be a problem. The different foods, they're now having to be in charge of what they put in their mouths themselves. They haven't got parents around who are making meals for them and screening stuff. They have to rely on either the buttery food, the dining room foods, or they go to the local supermarket and they shop, and we know that that can be problematic. Labels aren't always what they seem, are they? Add in alcohol. Many of these young people are coming to university and trying alcohol and pushing their limits and boundaries on that for the first time ever. Sleep deprivation is a huge problem. It's not unusual for university students to pull all-nighters, particularly at times of cramming when they've got exams or big tests coming up. They don't make their best decisions when they're deprived of sleep. So as I mentioned before, the possibility of having different sized devices may well make a difference in the future. And the time frame from their last reaction, or the seriousness of their last reaction, they don't always remember what happened to them. They might just know that they went into hospital, but they were okay. The hospital looked after them, and now they've got this device. So they become complacent about expiry dates. Sometimes they forget to carry, and sometimes they haven't made a plan. Also unease about self-administering. Some of the young people I've spoken to are really worried about self-administering and really don't know what to do. And I know there's good work done in the community clinics, the hospital setting clinics, but nonetheless there is still unease with some young people about how to inject. So we looked at these factors and we decided to do something about it. And we wrote a guidance. I was a co-writer, and I have to acknowledge my colleague Sally McCallum, who isn't with us today. Unfortunately, she's holding clinics in Cambridge. But she was a co-writer, and between the two of us, we looked at the guidance the university already had, and we had a think about what we could do to improve things. And then this came out. And it was a no-brainer, really. Morally, we should be doing something to help protect the young people. So 34% don't always carry their adrenaline devices. That means that 66% do, so they say, but we all know that the devices can fail and they're not always going to be delivering the dose as it should be. And also, this study didn't say whether individuals carried one or two devices. So who was the guidance for? The guidance was predominantly for the students and staff. So we looked at offering staff protection. Those who come into contact with an at-risk student or another member of staff, protection for them in that they have the empowerment to do the right thing in the situation of an emergency. To be able to identify, so a good training was key to that, and manage any additional training needs as they came along and presented. We were keen to provide information to the staff working in the university, offer resources, internal support, and above all, give them the confidence to act. For our students, we wanted again to offer them protection. This wasn't about shifting their responsibility onto us. Obviously, part of this protection is their own responsibilities for themselves. But it was key to provide more information to them, give them encouragement, support, and advice, ensure that they had recommendations that followed on from the good work in hospitals, and also encourage them to create a plan, because now they're in a new environment that needed to shift with their growing changes. also promote discussion and awareness within the university. As part of my background in a pre-hospital setting, I delivered first aid training for lots of staff and instigated the development of that. So I was keen to follow the principles of first aid. Those include preserving life, promote recovery, and above all, prevent deterioration. And that's what an AAI does, isn't it? That is a rescue medication right there. It's all of those three things. So the people that were consulted when the guidance was first written in 2014 was the Cambridge College Nurse Association. We have our own group, and obviously it's peer reviewed. We all have our opinions on what we should and shouldn't do as college nurses. So first of all, it went through that. Secondly, to Queen's College itself, where I was employed at the time, and the lawyers, pharmacists, and health and safety executives of that college. Then to first aid training providers, and they're the people that provide the training to the staff of colleges who would be acting in an emergency. The Resuscitation Council was consulted and lent their support, as the Allergy Clinic in Addenbrooke's did, and Andy, unfortunately he's not here today. The Anaphylaxis Campaign, of course, I spoke to them, and when the guidance was published in 2014, they put a link onto their website from it, so I was very pleased with that. And finally, it had to go through a University Health and Wellbeing Committee. So the questions that were raised by staff members predominantly, in fact, the students had very few questions about this change. So we were asked, is adrenaline safe? Can someone be allergic to adrenaline? And if you give them more, will it cause more of a reaction? Who could administer an AAI? What harm could be caused if you did? And what if a person does not have their own AAI? What if a casualty is not known to me? And what if they have an inhaler? What should they be given first? When should the casualty go to hospital? And what if I'm not sure what is wrong? So we addressed all of those questions as a group and through the Health and Wellbeing Committee. And along the way, over the last 3 years, there have been changes. So in 2014, as you all should be aware, the MHRA recommended that individuals at risk of anaphylaxis carried 2 devices at all times. And that's because we know that one isn't always enough, that the threshold for disease process can mean that one individual AAI doesn't target the symptoms, and another can be needed up to 5 or so minutes later. So we wanted to incorporate that, and our guidance was changed to do so. Secondly, many of the colleges had the interventions through catering organisations, and I know Hazel is speaking later today. So these organisations were brought in to meet with head chefs and catering departments to look at how we could better manage the risk process and labelling, advertising of food, trying to ensure that staff in the catering departments were educated and informed and knew how to answer questions about any allergens that might be in the food, but also how to recognise and treat anaphylaxis should they occur in a catering department. Those inspections still continue to this day. So where are we now? The guidance still remains, and colleges still stock generic devices. I must stress that we are nurses, we work in health professional settings, and we have endorsements of the GPs in the local area as well as the Health and Wellbeing Committee. However, there is hope in the future that we will get generic devices into university departments, and we are working very, very closely with the university and the various people involved in that to get generic devices in the departments themselves, not just in a college where a nurse works. That would be a huge step forward, and we're really, really thrilled to be looking at that. But there is still work to be done. I would like to urge you all, if you do not work with teenagers, but work with younger children, to support them in their transition into adulthood so that they are fully informed about the risks, about the challenges that they will face when they're living independently away from home. Commencing university can be fun. It really is intense, especially at Cambridge University, and it's vibrant and it's stimulating. But unfortunately, it can be daunting. It can be absolutely impersonal. There are hundreds of students joining in a big wide world that they've never stepped in before. It's overwhelming and it is challenging, and that's without having anaphylaxis on board. One of the things that college nurses do still is train staff within the colleges, and we, if any of you haven't done it, then I would endorse the Anaphylaxis Campaign training that you can access online. So, my last slide. I've come back to the title, A Maverick Approach. A Maverick Approach was an idea that was put to me when I first told a maker of an adrenaline device about introducing generic devices in a college. And he said to me, wow, what you're doing is amazing. Have you always been a maverick? And I thought, I don't even know what maverick means. Really, I only know of a character in Top Gun that's called Maverick. What does it mean? So I looked it up, and a person who takes an independent stand. I don't class myself as a maverick. I've worked very, very hard with other members who are equally as passionate and want to give the best for our students in an environment which is scary enough. Being a college nurse is a fantastic job. Any of you are nurses who want to get out of the NHS, I would urge you to consider it. It's wonderful. You have time for students, and we see them at the best of their times when they graduate, having sometimes been through the worst of their life experiences up till then. So my last slide is to say to you, think of me often. It's the motto of St. John's, and it means, sauvant mi sauvant, which I don't speak French, so forgive me if those who do. Think of me often, and think of the 4 lives that we have saved in putting in generic devices into university. Thank you. Yeah.
I'm a pedant for timekeeping, but if there are one question, I'm told. That gentleman was the first with his hand up.
I'm not a professional clinician. I'm an engineer, but I'm also the father of a son who died earlier this year. So just forgive me for a second.
It's okay. Take your time.
My question is whether you think there's merit in engineers, the engineers of the medical companies that might be here today, engineering a generic device that is actually more like this, that can clamp onto an iPhone, something which most, my son was 18, he had one, something which most kids will not forget and therefore will always take. And if that could be done, would you think that would make a big difference?
I think absolutely. I think there's work being done now behind the scenes by manufacturers to look at device sizes and try and make them smaller. I think that's key. Young people should not be afraid, for whatever reason, or reluctant to carry their devices due to the size of them. So absolutely, something that can go with a phone. They all carry their phones nowadays, don't they?